bring their cups and mugs. Hello, guys. This is Carlos.
After
We can see
standing,
you.
and
Yeah.
there was a mild stenosis distal to the stent, less than 5 millimeter mercury, and a mild to moderate stenosis proximal to the other stent, about 15 millimeter mercury. So we decided we overdilate with a Mullins high pressure 20 millimeter, and the pressure gradient almost disappear, about 15 or less proximal to the stent. So we decided to put the Melody inside just proximal than usual, in order to put a part of the covering stent proximal to the other stent we just implanted.
Okay, looks good. So what system you had said 18 before?
We decided to use a 18 millimeter valve that we try to dilate to 20 millimeter, because the inner diameter of the mitral flow is around 18.5.
Okay, go ahead. We have 10 minutes to wrap up the case.
Ok.
Vai,
Inner balloon. Vai, spingi.
vai, avvia.
Vai.
Vai. Okay. Other balloon. Ok. 3, 4.
Gonfia.
Portata 3, 4.
So how many atmospheres you're using on the outer balloon?
Up to 4 atmosphere.
4 atmospheres.
4 atmospheres should be 20. So we come back with the system.
Just for the sake of information, did you have any difficulty going across the previously implanted stent with your ensemble? Or
No.
did it go easy?
No difficulty at all. It went good. In our
Oh, that's
opinion,
good.
it could be quite small and quite tight, the conduit and the mitral flow, because there is some gradient across the cage of the valve.
Are you planning to take up the balloon again or take it out? You're taking out the ensemble,
Yes,
right?
I tried to take it out and to test the gradient, and at the end it may be to overdilate a 20 millimeter mercury, 20 millimeter balloon.
Perfect. I guess this is a Lander-Priest wire, isn't it?
Wait a
Devo
moment.
aprire, no?
Okay.
Ok.
Ok. chiuso.
Vengo dietro con
Close.
tutto?
Ok.
Sto venendo dietro con tutto. Ok. Put another time the 18 millimeter, 18 French.
Do you guys use any special closure, vascular closure device for this?
No,
For close?
no. We don't use closing devices at all. We put 2 stitches in the groin. Dammi il Mullins. Go ahead with the 7 French Mullins sheet. We perform the angel, and then we pull back all the wire. Okay?
Okay, do you do the angel with your long sheet, or you're
Yeah,
going to use
with a long sheet.
pigtail, or
No, with a
with a
long
long
sheet.
sheet?
There is no regurg at all.
Pressure.
And let's go to the pressure pullback.
Can we take
Is
a look
it
at the
around
monitor,
the one-
the pressure monitor?
Yes, is around 105
India 8.
in the aorta.
Okay.
Okay.
Can we show the pressure in picture? Pressure in picture?
Picture in picture.
No. Okay. Okay.
That's great.
Okay,
Small,
okay.
smaller
No, no,
the.
okay, okay, it's great.
Okay, perfect.
Or you prefer big the pressure?
Can you make the pressure monitor bigger?
Okay,
so
big
that
the
we can
pressure,
see the
please.
pressures,
Okay.
the pressures? Yeah,
And
perfect.
small the angio.
Yeah, that would be great.
Okay. So in the pulmonary artery,
Is around 50 in the pulmonary artery.
40.
40. Within the valve. There is some gradient below.
So are you planning to pulse dilate with a high pressure balloon?
Yes, I think so.
Maybe with a 20?
Yes, but I'm not sure that there is no a muscular stenosis at the site of conduit implantation. I don't know.
We
Okay,
perform
well,
an angio
we have
here.
to wrap up because we're running
we
behind
perform
here.
an angio here.
Can we see the angio big, please?
Okay, we had 2 more add-on stock. Otherwise, people are going to lose their flights back home. So
Okay.
I'm sorry,
Okay.
we have to close the session.
Okay.
Congratulations, a big hand of applause.
Okay,
Thank you,
thank you.
Pino.
Thank you. Bye bye.
Bye-bye.
Right. Okay. So please, John Thomason, come also to the
Bravo,
podium.
capisco.
We shall
No,
start
no,
soon the next session. There are some changes in the program because Ziad is going to give 2 presentations because he will leave today, and also Carlos is going to leave early next morning, so he will give his lecture today too. I would like to invite Dr. Besson to give the first lecture. We will deal with risks in cardiac catheterization, and we are really forward hearing about the invisible risk that is the radiation exposure. Thank you, Alain.
So good afternoon. My name is Hélène Besson. I'm working at the Laboratory of Epidemiology at the Institute for Radioprotection and Nuclear Safety in France. So I'm going to speak about the invisible risk in cardiac catheterization, radiation exposure. The cardiac catheterization procedures, CCPs, are medical interventions in which fluoroscopy is used for diagnostic purposes or for therapeutic purposes. The justification of TCPs is evident as these procedures give significant benefits to the patient with the possibility to correct congenital heart defects without complicated surgery. But these procedures may lead to high cumulative doses to the patient, and there are specific concerns in pediatric settings about long-term cancer risk effects. Radiation exposures in children with heart disease come mainly from diagnostic CCPs, therapeutic CCPs, and CT scans. These 3 procedures are responsible for about 80% of the collective effective dose. Why study young people? With their smaller mass, children tend to receive higher doses to specific organs, such as the thyroid or the bone marrow. There is a great variability of radiation doses, as there is no standard technique with which to perform a CCP. Dosimetric parameters are dependent on age, weight of the patient, and complexity of the heart disease. Historically, these dosimetric parameters were often ignored or not recorded. In comparison with adults, children have a longer remaining lifespan, more years at cancer risk. But more importantly, children have an increased susceptibility to radiation in comparison with adults. This knowledge comes from the studies of atomic bomb survivors. It comes also from studies on patients submitted to repeated medical exposure. And more recently, we have the results from the studies on children exposed to CT scans. Up to now, there are 5 studies on cancer risk after CT scan exposure in childhood. The results of these studies are consistent and show higher cancer risks among children exposed to several CT scans during childhood. But these studies need to be interpreted with caution, as there may be a bias by indication, because in these studies on CT scans, there is no information on the indication of the CT exam. Regarding cancer risk after cardiac catheterization in childhood, we have only 2 epidemiological studies. One was published in 1993 by McLaughlin. It was based on more than 4,000 children who underwent CCPs between 19